So we are ready to start and welcome everybody. And we are just going to I'm going to turn this over to Dr. Francoeur.
Thank you, Jocelyn. Bonjour tout le monde. Je suis Diane Francoeur. I'm the CEO of the Society of Obstetricians and Gynecologists of Canada. And today I am very pleased to be here with you to showcase some of our exciting work in the fields of abortion, endometriosis, and trauma-informed care. So you will see some very famous people doing very quickly a short turn about all the good stuff that they did, but it's a team effort. The whole team was working on that. And as an OB-GYN still in practice, even though I just work 1 day a week, I'm very pleased to see the work that we've done, because we need to educate women and physicians with the same language, with the same knowledge and the same information to be able to all together fight the misinformation that we see, unfortunately, too much often in social media. So the SOGC is really honored to have been a recipient of the funding from Health Canada's Sexual and Reproductive Health Fund to work together with experts and partners. And we have many partners, and we really, really thank you for all the amazing job that you've been doing. We were able to develop guidance and resources for the public, for healthcare providers, and for patients. We are thankful for the leadership and guidance of our experts and our partners, so that the work that we have done will be meaningful and inclusive of Canada's subpopulation. So today we will see some of the information and resources that our partners have developed specific for the African, Caribbean, and Black, Indigenous, and gender diverse population. So we hope that our efforts will help to improve evidence, understanding, access, diagnosis, treatment, and ultimately the quality of life of outcomes of millions of Canadians. I think that we are making a difference. I thank everyone, all of you, for all what you did in your communities. So we don't have a lot of time, so I'm going to just turn to Jocelyn, who is the master of the ceremony of this showcase, but also the master of ceremony of this amazing project that we did all together with the amazing SOGC team. Jocelyn, you're on.
Thank you, and welcome everybody. And as Dr. Francoeur said, I'm Jocelyn Cook, and I'm the Chief Scientific Officer at the Society of Obstetricians and Gynecologists of Canada. I'm going to do a little very brief overview of our project. And again, thank you all for coming. And we're really, really proud and excited to be able to talk about the work that we've been sort of consumed by, especially over the last couple of weeks. So about 1.5 years ago, Health Canada, through their Sexual and Reproductive Health Fund, funded the SOGC for a project called Building Bridges to Equity and Equality, Creating Canadian Capacity in Sexual and Reproductive Health, with the objectives to really understand best practices, gaps, and needs related to 3 key areas: abortion, trauma and violence-informed care, and endometriosis. And also to use this information as a basis and foundation to develop tools and models that promote patient-centered health through clinical guidance and patient and healthcare provider resources and information. And everything is centered and grounded in a trauma and violence-informed care approach, and also considering the needs of different populations in Canada. And so this is also very important. And our partners have contributed a lot of work and expertise in this area. And again, we're very thankful for that. And so this is an amazing graphic that I did not make, will never know how to make, and do not pretend it's my own, but it's very exciting. And our amazing project manager, Ken Koike, is really good at these things. And so but this just shows you that we're really interested in those clinical topics, the cross-cutting theme of trauma and violence-informed care, and everything we do is based on needs assessments, focus groups, environment scans, and many of you participated in those, and we thank you because we really do need that information. And then we worked with some advisory groups from the patient population, from healthcare providers, and created some tools and information and resources that you'll see a little bit about later. And this is a little bit of our model. This is how I make graphs and pictures compared to the one that Ken made in the earlier slide. So you can see that we always focus on kind of two streams: activities for healthcare providers and the activities focus on patients and the public, always based on focus groups, needs assessments. And then we think a lot about knowledge translation. For the healthcare providers, we have CME's continuing medical education events and workshops. We have a special issue in JOGC that I'm going to show you a little bit later. We have some scientific papers, websites and materials, toolkits with clinical practice guidance and podcasts and e-courses and resources and checklists and algorithms. There's so many things out there in both official languages. So that's also very exciting. And with the patients and the public, we already have material on our websites, but we wanted to make sure that it was current and up to date. And where we didn't have information, material, tools, and resources, we created some. And again, really worked hard with our partners to be able to create this information for the public and for patients, because everybody needs to have the same up-to-date information, be speaking, as Deanne mentioned, the same language, so that, you know, the patient-centered and partnered in care approach you know, is aligned and it's more beneficial for everybody. And I won't go through all the data, although I do love data, but we did an environmental scan. We did a synthesis of the literature in our topic areas, which we've based our sort of questions and the needs assessment. We have to know what's happening and know what's out there and take stock of the situation, because we don't want to reinvent the wheel. We want to be able to understand what's already out there when we're identifying gaps and opportunities. And so we did a whole environment scan. And again, many of you, thank you, answered our questions and surveys on this. We did needs assessments with the patient groups, and here's just an overview of some of the information that they told us, which we really took to heart. And I think that you'll be proud to see that it really is reflected in the work that we're doing. And so we talked a lot about, you know, co-creation of resources and being able to see yourself and your population in those resources, and increasing the visibility of medical professionals from the different populations, and really important to have information available in different formats. So different little video clips and messaging, and those are all really important. And then they talked to us about opportunities and challenges, and you know, gave some suggestions on how the SOGC could create content and materials and information and resources that would be helpful and meaningful to different populations. And so we heard a lot of information from the public and patients. And we also heard from our healthcare providers, because it's also important, again, to see where those opportunities and gaps are. And you won't be surprised to hear that the results were, there's sometimes limited opportunities to learn and to have hands-on training and education opportunities. Not having, you know, a pre-existing and trusting relationship, they felt, with care providers is a barrier. And we know that our healthcare system is struggling right now with capacity for healthcare providers, recurrent learning opportunities. And again, some really great suggestions with simulations on Zoom and video recordings, overview of medication options, clinical tools and algorithms and approaches and decision-making tools. And so I think, again, this information is really important for us to hear as an organization, so that, again, we don't want to do a lot of work and spend a lot of time and money doing things that aren't meaningful and helpful. And somebody did say the only way to learn is to continue to hear from patients from many diverse cultures. And I think that's, you know, a really important take-home message for all of us. And so I'm going to turn it over to Dr. Dustin Costescu from McMaster, who's going to talk about the work that he's been doing to update and revitalize abortion care in Canada.
Thank you very much, Jocelyn. It's a pleasure to be here today. Bon après-midi à tous. I'm Dustin Costescu. I'm a family planning specialist in Hamilton, Ontario. Just next slide, please.
Just a sec, I'm having a technical issue. There.
Great. So I'm really grateful to the SOGC and the team and our partners to really help us take abortion care, well into the current century and really improve care for everybody. As one can imagine, abortion is really a central tenet to reproductive justice and reproductive access. And so that said, it can be challenging for us to emphasize and grow our best practices because sometimes the work that we do is not seen in the same way as other forms of OB/GYN care, and our patient populations tend to be underserved, even though unintended pregnancy and abortion care really transcends all social locations and identities. When we initiated our abortion guidelines a few years ago, mifepristone was not available in the Canadian market. There were about 60 providers offering medical options to patients. There were a limited number of surgical providers, mostly in large urban centers, and many of our patients had to travel dozens to hundreds to thousands of kilometers to access abortion care. And in our vast geography, abortion was often inaccessible to these patients. In order for us to update the guidelines now, particularly I'm going to speak to the medication abortion guidelines, the landscape has completely changed. We now have a decentralized model where we provide abortion care across a variety of specialties, primary care, nursing stations, and we don't have many of the requirements in other countries that are significant barriers to abortion access. But we do see varying comfort with troubleshooting. And when we decentralize a practice, we want to make sure that there's consistency of care and best care anywhere in the country when you access abortion care. The other significant change for us has been that the pandemic has really launched widespread uptake of virtual care. We affirmed as an organization that abortion care is an essential service, but that we were comfortable, really growing the use of medication abortion in a virtual setting. This can be by accessing care completely virtually, or by a partial virtual option where parts of the care could be counseling sessions, it may be follow-up, it may be side effect management is provided in telemedicine or a virtual care setting. This is understandably as a novel concept, but we were able to grow from the evidence we have about the safety of medication abortion and really push for best practices early on. When we look at other countries around the world, Canada's had a very significant uptake of medication abortion. We now, about 30% of abortions in the country are medication, and that's on par with other high-income countries in terms of providing that access. We do have near universal funding for mifepristone. There are still gaps, and this is something that also gets identified in our equity work, depending on how you obtain health insurance or pharmacare coverage in the country. The other, large change for us and real elevation of awareness of medication abortion has been due to legislative changes in the United States, where now a majority of abortions are medication-based, and there are now a lot of media reports on what these medications are, for better or for worse, really emphasizing for us the importance of the organization to be a leader in terms of providing the best available evidence, not only to providers, but to the public. In terms of some key practice changes that we really wanted to affirm in our new guidelines, we want to make it very clear to Canadians and to providers that a medication abortion is an equivalent option to a surgical or procedural abortion when provided at an early gestational age, so under the 10-week mark, which means that if you're accessing abortion by pills in Nunavut or you're accessing a procedural abortion in Toronto, you can be reassured that these are both safe, roughly equivalent options. What's really important for us, though, is to make sure that we still offer the full spectrum of options to our patients. We know that some patients have a preference for the self-management or to be more involved in the management of their abortion, engaging in lower or no-touch options. And so medication, again, has opportunities for us to improve reproductive equity and access by putting power back into the hands of patients. One thing that we attempt to do in our new guidelines is to provide guidance to clinicians on when it's appropriate to let patients steer their own ship and how best we can provide guidance to them along their way to reduce the risk of harm, but also to improve outcomes and to reduce some of the psychological challenges from not feeling supported during an abortion journey. And again, really affirming, and there's going to be further discussion about this during today's talk. I'm not going to steal the thunder, but looking at ways to make abortion access more equitable across equity-deserving groups. One of the medical aspects of abortion care where there's room for improvement is around the use of Rh immune globulin administration. So for patients who are Rh negative, they may require Rh immune globulin to prevent them from having high-risk pregnancies in the future. But we know that Rh immune globulin is a blood product. It's a single source blood product in Canada. It adds time, it adds cost to providers, and it adds complexity to care. And that becomes a barrier if someone's not going to have access to abortion by pills, for example, because they don't have access to a blood bank or to a nursing station. And so every small aspect of systematic delay compounds itself, which renders abortion inaccessible. Patients present at later gestational ages or have to travel for surgical services. So for our ability to provide greater guidance and review the evidence on this, we can say that, by updating the guidelines, by taking a more restrictive approach to RH, and we're a little bit embargoed in terms of some of the specific recommendations, we do believe that that will help improve access both to medication abortion and to procedural abortion across the country. And as we continue to review the evidence, from increased utilization in the country, when we listen to patients' stories and their experiences, we will continue to reduce barriers to abortion care across the country. In terms of future directions, there's always room for improvement. We know that globally abortion contributes 16% of maternal mortality, and yet we're really only talking about it now. And I really value, our funders in the organization for being bold and not shying away from a really important aspect of reproductive health care. We do recognize there still are inequities in access. And as a guideline author, what I can tell you is we're still not capturing all of these voices. And so we need to have novel ways to ensure that these voices are heard as we put guidelines together and as we translate that knowledge for end users. In terms of another aspect where abortion science is really important to us is in the area of miscarriage management. And one thing that we hear across all populations, and in particular in our equity deserving groups, is that miscarriage management is one of the great untold and unmet needs in terms of providing compassionate care. We can use both the resources in clinics where resources are freed up by the increased uptake of medication, but also in terms of the science to help provide timely care to these patients and give them greater control of their reproductive outcomes. And we continue to watch the global landscape because we know that when large countries change legislation, we have to answer as to why we are not changing and why we continue to believe that we need to have access to these options. And so this is a day-to-day challenge for us, but we as an organization also need to be able to respond more rapidly than in the past to make sure that we reassure the public of availability of medications and to the safety of the care that we provide. And so I want to thank you very much for your time. It gives me great pleasure to shift gears to a completely different area of reproductive health, which is endometriosis. And it gives me great pleasure to introduce you all to Dr. Sony Singh, who's going to take it from here.
Great. Are we okay to go ahead, Jocelyn? Perfect. So thank you again, Dustin, for such a great overview. I'm going to be speaking to you about endometriosis. And definitely when we look at equity, equality, or access to care, endometriosis is definitely a condition that needs that attention. And this project, amongst many others, are highlighting the importance of that area. Next slide. So a couple of stats and a couple of pieces of information. So endometriosis is common. So 1 in 10 girls and women are estimated to have endometriosis. The true number is actually much higher. And there's an unnumbered, unrecorded, population out there of gender diverse individuals, which we also need to help get access to care and understanding as well. Overall, you can see that there's a huge delay in getting endometriosis care. In our own clinic in the Ottawa region, up to 5 to 7 years from a time a patient presents with the condition to the time they actually get the care that they need. The cost to society, to families, to the whole system is significant. And when we have individuals who are impacted with endometriosis, whether it be symptoms of pain, such as dysmenorrhea, painful periods, dysuria, painful bladder, painful bowel movements, or dyspareunia, which is pain with intercourse, all of those can significantly affect someone's quality of life and ultimately their whole potential in life. So it is so important to not only put a highlight on this, but to realize this disease or this issue has been around for thousands of years. And even in the last hundred of years, we haven't really moved the needle up until recently. And so with the SOGC's help, with funding like we've been able to get, with partnerships with groups like the Endometriosis Network, the Endo Act, which is our national advocacy group, amongst many other patient organizations, the voice is elevated. And I must be honest, it's not the physicians, it's not the healthcare providers who made that change or advocated. It was truly from the grassroots, from the patients, from the families who were impacted and affected. And they spoke up to really highlight that this was a disease that has been dismissed largely and now needs the attention and obviously needed it before. And next slide. So coming up soon, and there are some co-authors online, is our guideline on impact and diagnosis of endometriosis. There was a very specific decision to separate the treatment guidelines with the impact and diagnosis because the impact alone needs to be communicated. The impact on the individual, the impact on families, and even more importantly is the section on the impact on populations that traditionally weren't even recognized to have endometriosis, and that includes Black women. And I think that at the end of the day, there's a huge amount of work that we need to do outreach. There needs to be education amongst our healthcare providers, but also amongst the rest of society, whether it be schools, teachers, working through the healthcare system. And much more. So our goal is really to get the word out, to reduce the time to diagnosis, to get education and awareness out there, and to make it a wide collaborative effort. And really, if you hit next slide, there's a build there that'll show that this guideline, oh, back please. Yeah, that it was done with patients, researchers, healthcare providers, and professional organizations who I've mentioned a few of as well. Next slide. So finally, what we're going to do with the current guidelines is really work on knowledge sharing now, make people understand that endometriosis is extremely important, likely has a larger impact than is estimated as we go forward with our communication. So we're going to be doing the e-courses. We're going to help convey this at meetings and conferences, work with patient organizations. The Endometriosis Network has done amazing work on getting the word out during this month, which was Endometriosis Awareness Month. Next steps are the treatment guidance. So that's something we're going to be working on that really looks at a patient-centered approach. And different than what we published almost 15 years ago is the importance of holistic approach towards looking at managing endometriosis, whether it be through managing pain, through medication, surgery, which is traditionally what we're taught, but there's so much more. There is an interdisciplinary model that looks at pain education. It looks at physiotherapy. It looks at understanding the full journey of an individual from adolescence past menopause and how we're going to work together. So again, thank you to the SOGC. Thank you to all the partners who've come together to do that. And now I hand it off to Dr. Heather Millar to talk about trauma and violence-informed care.
Hi, thanks so much for the introduction and for having me today. I'm Heather Millar. I'm an OBGYN in Toronto. I also have additional training and a bit of a practice focus on pediatric and adolescent gynecology, global health, and family planning. And I'm happy to be speaking today about trauma and violence informed care and some updates. And I think Jocelyn, okay, yeah, that's good. No, that's good. So one of the things that Jocelyn mentioned at the beginning that's really important were the objectives for this project, that while there are these sort of specific topic areas that are important, one of the main goals was that all of this work have a foundation in trauma and violence informed care. And that's because we know that trauma is very common in all populations, in all the patients that we see, and that many experiences in sexual and reproductive health and in obstetrics and gynecology can be traumatizing or re-traumatizing for our patients, as well as sometimes for providers as well. And the concept or the approach of trauma-informed care or trauma and violence-informed care involves an understanding of the prevalence of trauma, that what we do can be traumatizing or re-traumatizing, and then uses specific approaches to try to minimize those experiences of trauma or triggering, and engage our patients, provide empowering care that then hopefully in the long run leads to improved health overall. And then we know that trauma and traumatizing experiences can be more common for some of our most marginalized or equity deserving groups of patients who we care for. And so really this is something that I've been very excited to be involved with, and very excited that the SOGC feels so strongly about trying to have this overall approach to what we do. And this very much relates, of course, to abortion care and endometriosis care, as both I think Dustin and Sony sort of touched on as well. And so what we've been doing so far, so there is a CME module that has been developed to provide an introduction to trauma and violence-informed care for reproductive health providers, specifically to what we do as obstetrician gynecologists, as well as all of our other health providers who work with sexual and reproductive health. And then we are currently working on developing an SOGC guideline on trauma and violence-informed care in obstetrics and gynecology. And a lot of this so far has been a really important process of thinking about who our authorship should be on a guideline on this topic in Canada, and what do we think is important to offer in a Canadian guideline compared to other guidelines in this area. And so it's really been a very thought-provoking experience so far. We have authorship from across Canada, including 2 Indigenous co-authors, as well as 50% of our authors with experience working in Indigenous health. And we've spent a lot of time really discussing how do we write a guideline that is rooted in particular, the Indigenous experience of trauma in Canada, and thinking critically about how we care for equity deserving groups and how we address that within this guideline. So that will be hopefully coming out, or will be coming out in 2024. And a large part of that guideline as well is going to be to aim to provide practical implementation guidelines for providers. And while we're talking a lot about the Indigenous experience and that being a central part of thinking about this topic in Canada, the goal will be that this will be applicable for all patients and any equity deserving group. So really looking forward to continuing to work on this, and it's been very exciting to have support and enthusiasm for this topic area, and a lot of people across the country who are excited and eager to be involved in producing these resources.
Perfect. Thanks, Heather. And so you've all heard from my new 3 best friends who probably have me blocked on email after this. Hi guys, how's it going? How are our guidelines coming? And they've all, worked really hard to be leading those groups of experts and working again in partnership with all of the folks. And so thank you to all of them. I'm going to do a very quick bird's eye view of some of the resources that we've developed just overall for healthcare providers, and our amazing communications team that was, an N of 3, that's an N of 3, has worked really, really hard to develop web sites and materials and graphics. And so we're very grateful, and we're really excited. And to many of you also who've given us suggestions about the resources. And so the SOGC websites are it's like a hot potato. So any day it could be a little bit different because we're continuing to refine the process. And so our new web content is out there and available. And so if you go to the healthcare providers, resources are going to be hosted. If you eventually, maybe tomorrow or later tonight, go to SOGC.org. There's going to be a button that says resources. You don't even have to be a member to access those resources. And there's resources for patients and the public, and there's also resources for healthcare providers. The other thing that we've done is, so it'll look sort of like this. So there's content, there's links, things are organized into multimedia. We had team multimedia with podcasts and with webinars and some presentations. We have clinical guidance that link to our guidelines, and we have tools and resources like was suggested in those focus groups, algorithms and decision aids. What we thought was really important also to link to the resources that we've also developed for the patients and the public, because sometimes healthcare providers need to know what's out there and what information is available for their patients. And so it's really important, again, to have all of the same information sort of packaged in in a toolkit for healthcare providers, and then they also have access to the patient resources. The other thing that we've done is sort of made hubs of information that's relevant to different populations. So information that's relevant for the African, Caribbean, and Black population, for the Indigenous population, and for the gender diverse population. And so this is just an example. We have the 3 main hubs. We have abortion, endometriosis, and trauma-informed care. And of course, there's linkages back and forth. And so that's really exciting. And so that's our website kind of material. And then if you look, Heather mentioned a bit, and Sony, about the e-courses. So we do have new e-courses that have been developed, online courses geared toward healthcare providers. We have the endometriosis course, we have medical abortion training 2.0, and the procedural abortion one coming very shortly. It's, I think, in translation. And then we also, as Heather mentioned, have our trauma and violence informed care online course. And so those are also included in the resources included on the SOGC's e-course page.
Oh, sorry. I thought you'd be done. That's okay. You were in there.
Oh, somebody's not muted. Okay, somebody's on that. We've also created content, and this was done by SOGC staff, so thank you. Some tools for healthcare providers who can print things, posters, and even put them in your office. And so here's just one example for an inclusive space in the office, and you can modify those to any content, but that's been developed, and as well as some pamphlets even in terms of patient decision aids, and lots of actually information that's out there that we've been able to link to that other partners have developed, but also some things that we did develop in-house. And there's a lot of content, so I encourage you to look when we press live on those websites any day now. The real deadline is March 31st. But on like I said, on the resources for abortion, trauma-informed care, and endometriosis. The other place that this information is going to live is in the SOGC member site also. And so it'll be easy to access from both places, from, before the member login and also after, just to make it easy. We also have a special issue in the Journal of Obstetrics and Gynecology Canada on endometriosis, and it's live, and you can see that on the GOGC website. So there's science and evidence and papers that have been written, and so it's exciting, and that's also linked as a resource so that we can kind of stay up to date on that changing evidence and science. And then we've given a lot of CMEs and workshops over the last year, focused on the different areas that we've been talking about again. And so these are also packaged and bundled into the resources for healthcare providers. So you'll be able to just click on it and have access to the YouTube videos and to those slides and that content. There's Sony up there, and he's the only one in blue. And so again, we have experts who create this content, and so having it made available and accessible, I think, is really important. And so again, thanks to all of you who've had a hand in this. Finally, I'm not going to say that I'm a really great podcast recorder, but we've all learned to record podcasts in our office lately. And so many of the voices in podcasts are probably on this call. And so we have experts, again, from all across the country who've been talking to patients and who've been talking amongst themselves and to other experts about content that's really important. And so as the podcasts are published on Spotify and on Apple Music and wherever else podcasts go. We're also linking them again to our resource sites, both from the patient end and on the healthcare provider end. And so it's really exciting, and you learn a lot when you're a podcast recorder. And so it's great. And hearing the patients talking about their experiences and how thankful they are for the types of resources and tools that are becoming available is really inspirational. And I think, and it really gives meaning to all the work that we all do. And so, I think that's been a great experience. And so again, thank you to all of you who've done the great podcasts. We also have resources for patients, and I'm just quickly going to show you a few snapshots of our new content on our websites, and you're going to hear from the folks who developed a lot of that content as experts after me. We have information on the Pregnancy Info website, pregnancyinfo.ca, on yourperiod.ca, and on the sexandyou.ca website that are SOGC's kind of public and patient-facing websites. And so again, all the content is aligned. It links back and forth with the resource kits for the healthcare providers, and also those resources at the bottom are linked also for the patients and the public. And again, trying to make sure that we're all have the most current, up-to-date content and speaking the same language. And so this is just an example, but all of those websites have the appropriate content that has been developed, integrated into those. And thankfully for our Dave, our amazing website creator, there's so much information there. And you can also see that, again, that the tools and resources for patients are grouped into websites, multimedia information and tools, and then the different specific resources for the African, Caribbean, and Black patients, gender diverse and Indigenous patients. And so as we get more material, it's end of the year, everybody's scrambling and finishing up and finalizing all of their content, but it'll all be uploaded and you'll be able to click on it and have access in both English and French. And so we're really, really excited about that. And we're really proud of the volume and the quality of information and content that's all evidence-based, all current, all up to date on our website. So please, we're excited for you to look at those. And some of the content, like I said, I'm going to turn it over to the experts and our partners who we worked with really closely to develop this information. We just packaged it, but these guys are the real brains and skills behind the information. And so Sarah Monroe from the University of Washington is going to talk to you about some of the resources that she developed specifically for patients, right, Sarah?
Yeah, sure thing, Jocelyn. Thank you so much. So I'm Dr. Sarah Monroe. I'm the co-director of the Contraception and Abortion Research Team, CART, and I just left the University of British Columbia to take up a new position in Seattle this last January. And I'm here to talk about the work that we've been doing through CART to develop patient-facing resources for people seeking abortion care. If you go to the next slide, please. This has been work that's being conducted in partnership with SOGC as a way to make sure that we are disseminating this information as widely as possible and on trusted platforms. I have to thank Ken Quickie and the team for supporting us in doing this work. The Medication Abortion in Canada page was really led by Ken and the different individuals involved in that team. What you'll find when you go to this site when it's live is information about what is an abortion, what are your options, what can you expect during an abortion, as well as resources to help patients access a provider closer to home, to get post-abortion support, and to access resources that can support trauma-informed care, gender-affirming care, and culturally safe abortion care. Also linked with this page, if we'll go to the next slide, is a patient decision aid that has been developed by my team called It's My Choice. It's a tool that supports people to consider their options for method of abortion in the first trimester. And interestingly, I hear when I talk about patient decision aids, people think, well, I already have something like that. We have information on the website, but I like to clarify what a decision aid is and how it differs from other resources. So a decision aid aims to support shared decision-making. It helps to prepare an individual to make a choice by not only giving information about the options and the potential pros and cons of those options, but it also includes exercises to help the person making the decision to think about what it matters most to them. What are the features of the decision that align with their preferences and needs? And this is why it's different from information alone. The Cochrane Review of Patient Decision Aids, which was just updated a couple of months ago and published again by researchers at University of Ottawa, it's been cited by over 70 clinical practice guidelines because patient decision aids are the patient-facing version of clinical practice guidelines. They not only provide information and talk about the benefits and harms of different options, but then they also help patients to make evidence-informed choices that match with their preferences. The Canadian Medical Protective Association also talks about decision aids being really key resources that are better than information alone in helping a patient make an informed choice that's autonomous as well as well-informed. And also decision aids in the space of reproductive care can really be helpful to support the prevention of reproductive coercion, which is something we always want to think about when collaborating with equity-deserving populations. So Here's My Choice. We developed this interactive website between 2019 and 2023, and that was through leadership by myself, my doctoral student Kate Wall, and our collaborator, Dr. Melissa Brooks, who's at Dalhousie University. We created the initial prototype with an advisory panel of clinicians who include people who have co-written the national SOGC guidelines. We also had a diverse sample of interview participants, and then we tested its usability and just have wrapped up the effectiveness study, a trial involving over 300 participants. When Health Canada approached CART and said, we have this funding available, we saw it as a great opportunity to disseminate this tool, but also to culturally adapt it. To make sure that this resource was going to be going a step further and meeting the different needs of different populations when they're considering abortion care. So this included translating our tool into French, Punjabi, and simplified Chinese. We created a video that explains the purpose of the tool and includes captioning in all 4 languages. And we chose these 4 languages because they're the most commonly spoken languages at home in Canada. And finally, we ensured that it's mobile friendly and can be used across a number of different platforms and on low bandwidth as well. So you see here the URL, it's currently live and we're thinking about implementation. Beyond just making this available, how do we want this tool to fit into routine care? So for clinicians and allied health providers who are joining here today, how would you share this with people who are considering their abortion options? Is it something that can be shared through a conversation with a staff person at intake or via email or text when setting up a first appointment, on your clinic website, or maybe through a QR code in the waiting room? Second, we've been really delighted to receive additional funding from Health Canada for this next year, and this will include the development of more videos. What is a medication abortion? What is a procedural abortion? And then how do I ask a clinician for an abortion? Again, we'll be translating into 4 languages, and ideally, these are going to better support equity-deserving populations to learn about their options and choose the method of abortion that matches their informed preferences. So thank you, Jocelyn, thank you, SOGC, and thank you, Ken and team, for supporting and collaborating in this work to make the patient decision aid more widely available.
Thanks, Sarah. And again, really exciting. And this is going to be available very shortly. We're just waiting on the algorithm math in the back end to get uploaded on our on the patient resource websites and also on that section for in the healthcare provider resources. So again, all kind of in making things easy to get to. So thanks, Sarah. And now we have Elsie Amoako, who I had the pleasure to meet. We both are working a lot in the space of perinatal mental health, and we got really, really excited to be able to work together. And Elsie is the executive director at MenoCare, which used to be called Mummy Monitor. And I see she's having a MenoFest, which I'm totally going to. And so I'm just so excited to have this partnership with Elsie. And so over to you, Elsie, because she's really been leading our work related to the African Caribbean and Black community.
Yeah, Hi, everyone. My name is Elsie Amoako. I'm the founder and CEO at Mino Care. You can go to the next slide. We connect Black parents with various perinatal and reproductive care services. So Black birthing persons, Black women, we connect them with various things like doula support, mental health support, pelvic floor therapy, connect them with midwives, pregnancy massage, you name it. We basically connect them with it, social workers and the like. We can move on to the next slide. We've been serving over 1,000 clients, and we basically get them referred directly through healthcare institutions. So hospitals, CHCs, midwifery clinics, and the like, typically will refer their clients to us if they want to provide them with extra support. With the SOGC, we have the amazing opportunity to do a partnership and do a campaign around endometriosis for the ACB community. And a part of that included a podcast episode, which we filmed with Dr. Tanya Williams, with Joanne Posidolo, excuse me for mispronouncing her last name, but she's a registered physiotherapist and certified pelvic floor therapist who works directly in the reproductive healthcare space, and Denise Campbell, who is a patient with lived experience, who is also a director or a part of the board at the Endometriosis Network. So this is going to be amazing. We're going to be taking clips from this. We're going to be sharing it on social media to ensure that we continue to educate and share knowledge within the ACB community. In addition to that, we'll have the audio available for the podcast in addition to a video. We can go to the next slide. In addition to that, we're also doing a health promotion campaign as well, where we're sharing these posters that we've created with the ACB community. This will also be available for people to use as well. But we talked to some other patients from the Black community with lived experience, in addition to the professionals that we work with directly on our team and otherwise. And we just took some of the key points from the education information they provided around the lived experience of the Black community when it comes to endometriosis and what they need to see, and a better way to engage them in care and help them to be more educated about the experience. And with that, we created these posters to hopefully help us to further engage them. And the last thing we created is a pain logbook or a pain diary. So the reason why we called it logbook is just because of the wording, again, with the feedback we received from the community, trying to ensure that we remain sensitive to their needs and experiences. We're going to have a booklet that will be available to patients that is culturally safe for ACB client patients, and they'll have the ability to use that to allow them to first be educated about what their period pain looks like, understand whether or not they can be diagnosed with endometriosis, and then in addition to that, from there, understand how to manage that and what to do and just keep track of their symptoms and experiences overall. So yes, that's all we did, and I'm excited to be a part of this. It was a wonderful experience.
Thanks, Elsie. And these, again, will be available on all of our resource. They'll be linkable in all of our resources for patients, the public, and our healthcare providers. So again, an amazing partnership. And so I think it's really a great opportunity. And we're, again, really excited to have had this opportunity. And we're going to continue to do a lot of work together in the future. And now I'm trying to go over. Okay, now I'm very excited to introduce you to my friend, Dr. Nancy Poole, who's the director at of research at the Center of Excellence for Women's Health. And I've known Nancy and we've worked together for a really long time. And she really is a leading voice nationally and internationally related to girls, women, gender, trauma-informed practice, information, resources, substance use, all kinds of things kind of all packaged together. And we know that it all is interrelated and touches so many areas. And so Nancy has been kind enough to help us develop all of our content on our patient-facing and public websites. And so over to you, Nancy, to talk to us a little bit about what you've done.
Well, thanks, Jocelyn. And wow, what amazing stuff has been done in the course of this project. I've so enjoyed hearing from everyone. So the Center of Excellence for Women's Health is a research, nonprofit research and knowledge exchange center that's hosted by BC Women's Hospital and Health Center in Vancouver. And we've been around a long time in trying to do the very thing that I was able to do in this project, which is closing the loop between research and practice to bring about both social change and health improvement. for women and gender diverse folks as well. So just turn to the next piece here. Yeah, so I don't have a million slides to show you all the different subsets of things I've done because the trauma-informed piece has really been woven in to a lot of the different aspects that Jocelyn's talked about today. It's part of the healthcare provider information and modules. Hopefully it will be part of the guidance that comes out. And also there's a lot of patient-oriented materials as well. And the picture here is one example where, you know, I found it really interesting to bring all the work I've done over the years around trauma-informed practice with different sectors to bring it into this place of pregnancy and OBGYN related issues. And one of them was in this area around giving consent for sex in the Sex and You public facing piece. And so, you know, I think it's a really fun thing to think about how both healthcare providers universally offer trauma-informed support, but even equally important, as you've heard from the others throughout here, how patients are also active agents in this whole process. So one of the things I built in this was translating what we know about trauma-informed approaches into helping patients think about how they find support that's trauma-informed and how they are able to ask and tell providers about what is safety for them, how they want to be involved in the choices, you know, if they want to hear more about the options, etc. How they can really find a reparative relationship with their healthcare provider in the course of this. When they've had experiences where, you know, relational connection has been really challenged. And really, for both providers and women to be in this place of learning and practicing self-calming skills together when anxiety gets high, and also to really constantly be thinking about how we can affirm and notice resilience and strengths as well. So it was so fun to bring research to these very practical things. And I really hope they are concrete and helpful. So thanks, Joss.
Thank you. And I have to say it was the Center of Excellence for Women's Health is a big source of resources and information for us and all of the work that we do. And we're thankful it's in both languages. So keep up the good work on that. And so this is the end of our sort of official showcase and launch. And I just want to thank our speakers and everybody else. And I'm turning it over to Dr. Francoeur to do the thank you and the closing. And so bye-bye from me, your host. Nope, not Dr. Faustina. He's not on mute. Oh, you're not on mute. Dr. Francoeur, where might you be? Okay, well, I'm not really sure where she is, but that's okay. I will take over. And so
I'm there. I'm there, Justin.
Okay.
Okay.
Okay,
but
perfect.
there's a noise. I don't know where it comes from. So, oh, that's better. Okay. So sorry, don't go away. I have a great announcement to make. First of all, can you imagine the amount of work that there is into that? So it, as we say, it takes a village to do all that stuff. It takes a lot of experts, and I just can't thank you enough because you've been very generous to help us to put all of that together. And I would also like to thank the staff because we're a small team. We're just 38 people, and Jocelyn stopped us from breathing for the last couple of weeks to make sure that we meet our deadlines, because at the you're dealing with funding, you have to deliver on time. And I really thank all the team that we were able to make it. So now, speaking of funding, I'm gonna take my sheet because Justin told me to respect what was written. So we got a good news. So the SOGC is delighted to announce the approval of a 1-year extension from April 1st, 2024 to March 31st, 2025 for building bridges to equity and equality, creating Canadian capacity in sexual and reproductive health. So this is a great news. So we're just gonna do more stuff, more tools, more whatever you need. And it's really important that you tell us what you need, because we're working for you guys. We're working for the women. We're working for the girls. We're working for the LGBTQ community. We want to know what you need to make it happen. So supported by the Sexual and Reproductive Health Fund Vision, Health Canada, the SOGC and its partner will carry out in-person and online activities that expand the impact of our endometriosis-related efforts this past year. So the key highlights of this extension include national grand rounds, webinar on topic areas identified as priorities in the initial project period and based on the endometriosis guidelines. We know that people like webinar because they can listen to it whenever they are ready and they have idle time. We're going to do in-person workshop on clinical recommendation for management of endometriosis. And we're going to do refinement of patient and public resources and further dissemination of these resources, because waiting time in this country is not good. We have to make sure that, whenever the patient can have an appointment, they know better than their care provider, and they're going to be able to ask for what they need. That is our purpose. So stay tuned for updates on our endometriosis work in the coming year. Follow us on social media and subscribe to our newsletter for the last news and events related to this project. So thank you, Jocelyn. You've been amazing. We're all dead, but we're happy.
Thank you, everybody. And it was great to hear from all of our partners. And guess what? The fun is going to continue. So stay tuned as the resources start to be uploaded in real time. We're so hot off the press that things are being uploaded in real time. And so what a great opportunity. And so thanks, everybody. And go and enjoy your day before your very long weekend. And we'll all be in touch. Au revoir. Bye-bye. Au revoir.
Bye.